Excellent. As I said, welcome everyone. This is a webinar around our competitive research grant round, Advancing Care and Treatment of Chronic Conditions in Priority Populations, which will be opening on Monday. This is the first time we've run a webinar, and we thought we'd probably better run a little bit of an explanatory webinar for this one, because it is slightly more involved than perhaps our previous types of rounds that we've run. So before we get underway, I'd just like to acknowledge the Kaurna people as the traditional owners and custodians of the land we meet on today, and we respect their ongoing spiritual relationship with their country, and we respect and honour elders past and present, and pay our respects to the cultural authority of Aboriginal and Torres Strait Islander people visiting, attending from other areas of South Australia and Australia. So just a brief rundown of what we'll go through today. I'll give you a brief overview of the Hospital Research Foundation Group, just as a bit of context. We'll then talk about the round objectives and the various requirements. As I said, it's a little bit more involved than some of our usual rounds, so we'll pay a bit of time and effort on that one. Talk about the assessment criteria, the application process, and a Q&A. Now, this is a Teams webinar, which we are recording, so if anyone has any, I guess, issues with recording, not that I think under the webinar rules you're unable to actually put forward comments verbally anyway, but we do have a section at the end for Q&A, and the Teams app should have a section where you can enter your questions, and then at the end of the webinar we'll run through the questions and provide answers. The slides and recording will be made available after the webinar is complete, and we will also use the questions that are entered to provide a response, like an FAQ type document as well. Okay, so briefly, the Hospital Research Foundation Group is a group. It's an umbrella organisation in some ways. So we've got 12 charities that exist under the THRF Group banner. And I won't read the text for you there. I'm assuming you can all read, but I guess just wanted you to sort of have a look at the various types of affiliate organisations that come under that banner, and these affiliate organisations and entities have, if you like, informed some of the construct of this particular round, particularly as they pertain to chronic conditions. And also under the Hospital Research Foundation Group, there are a number of initiatives that we run. There's the Walk to Fight Parkinson's, there's the Longest Table, which is around cancer, there's Brain and Body Fitness Studio, which is about trying to improve health for people with some of the neurodegenerative conditions. Under our roof, which provides accommodation services for people that need to come into the Adelaide city for treatment, often from rural and regional areas, but perhaps don't want to stay in a dormitory style accommodation, so that they're sort of well-equipped houses. And our home lottery, which hopefully all of you have bought tickets in, and many, many tickets, because that helps to fund what we do, which I'm about to get onto. So our funding, I guess the important thing to note is we don't receive government funding for research. Essentially, all of our funding for research comes via the home lottery, as well as donations, bequests, some corporate and community giving, and those sorts of things. So it's we're not government funded. We see ourselves, I suppose, as a custodian of community funds, and that's, I guess, important in how we go about it. We want to make sure that there's the right governance and appropriate use of those community funds. So without further ado, I guess just a bit of background around the Advancing Care and Treatment of Chronic Conditions for Priority Populations round. Chronic conditions are an increasing focus, and I mean that's probably nationally. There's a lot of work with, say, the Medical Research Future Fund. That's a focus area that they've got, a priority that they've got. But it's also become an increasing priority for us, the Hospital Research Foundation Group, as an organisation. Those affiliate entities that I talked about a little bit earlier, a lot of them are dealing with services for chronic conditions, and we've found that an area of increasing demand for those services, particularly in the Parkinson's, stroke, arthritis space, among others, of course. And I guess the focus there is also brought about by we often regularly, let's say every 2 years, run a supporter survey where among many things, we ask supporters and donors what some of their focus areas, what their interest areas are. And probably historically, it's been predominantly cancer. But we have noticed a shift in the last couple of years that started to become much more around some of the chronic conditions and living well and quality of life. So again, that has informed the structure of this round. Also, I've jumped ahead one, just excuse me a second. I'll go back. There we go. And I think there's also an increasing recognition that there are populations out there who don't necessarily have the access or the equity in treatment or care, and we want, as an organisation, we want to see that increase, and so we want to reduce the health inequity and disadvantage. We want to see increased access, increased treatment, and so that it doesn't matter where you live, who you are, where you're from, that you have that access to care and treatment. Well, we as an organisation are also very keen on collaboration. We want to see it across discipline, across organisations, across borders even. The eagle-eyed amongst you may have seen in our discussion around the THRF Group that we have recently had a foundation from Western Australia join the group, and so that has sort of informed what we're thinking about for this round, and we will be encouraging, not requiring, collaboration across borders as well. And we're also keen to support emerging researchers, and that again is a facet of this round. I guess the overall objective of the round, we're hoping that we'll get proposals and we'll be able to fund projects that can help to improve the health outcomes for priority populations by advancing the care and treatment of chronic conditions, hence the title of the round. Now, the basic round parameters, essentially it's a competitive research grant round, so we're looking for, I guess, research proposals. The funding available for a project is up to 250K over up to 2 years. How many projects that we'll fund is probably somewhere up in the air, but a ballpark might be around 10, let's say. We have a staged application process. Stage 1 is an expression of interest, an EOI, followed by an invited stage 2 full application, which is much more detailed, and they have to be submitted via the eligible administering institutions that we have on our list, and they are essentially the South Australian universities, South Australian Health and Medical Research Institute, the local health networks, Carlin, Sarlin, Narwin, Witchen, and the rural health networks, which tend to be administered via the Rural Support Service. We have allow for up to 4 CIs, but the CIA has to be a salaried employee of the admin organisation, which means, so in the example of a researcher who's employed by a local health network but is a non-salaried affiliate of a university, they would need to apply via their local health network. We also want the CIA, in terms of supporting emerging researchers, we want them to have an HDR and be less than or equal to 15 years equivalent post HDR conferral or equivalent. So if someone feels that they have the equivalent experience and the equivalent, if you like, career span that meets the similar level of having an HDR and being within 15 years post HDR, they can also apply as a CIA with some evidence. I'll talk about that a little bit later. Now, as I mentioned, there's this round is slightly involved. What we've required is that proposals really need to incorporate 3 elements. that we want to see in each proposal. So element 1 is that it has to target one of the designated chronic condition focus areas. I will go through those focus areas in a minute, and you will probably notice how they broadly align with some of the entities under the THRF Group banner. The little number here, 2.2.1, refers to the section in the guidelines, which provides a little bit more detail as well. And obviously element 2 is to involve a priority population for which that targeted chronic condition is relevant. Section 2.2.2 of the guidelines. And element 3 is to undertake one of the two research approaches to advancing care and treatment. And again, I'll go through all of these elements in a little bit more detail, but they're the three constituent parts that we want to see in a proposal. So element 1, the chronic condition focus areas. Proposals will have to primarily target one of the following areas. So we've got chronic kidney disease, chronic pulmonary respiratory diseases, including lung cancer, diabetes type 1 or 2, mental health conditions, including eating disorders, neurodegenerative conditions, including dementia and Parkinson's, rheumatological and other chronic musculoskeletal conditions, chronic vascular disease, including stroke and stroke sequelae. As you can see, that's quite a broad list. Many things captured under that list, and you'll probably recognise a few of them have reasonably direct correspondence with some of the entities under the THRF Group banner. Often chronic conditions don't exist in isolation. There's comorbidities involved. We are particularly happy for comorbidities to be part of the research proposal, but they have to address the chronic condition primarily. Related comorbidities are a welcome bonus, if you like. But there's by no means do you have to address all of the comorbidities of any particular chronic condition. We want people to focus on a chronic condition. Element 2 is the priority populations. Now, proposals obviously have to identify one priority population for the purposes of the research. We don't want multiple priority populations. I think that's probably unreasonable with the level of funding and the up to 2 years. But so one priority population. Priority populations aren't necessarily strictly defined, but there are various documents out there which give a fair indication of the sorts of populations that suffer, disproportionate disadvantage or health equity issues, or need, special consideration as to how their particular conditions can be dealt with and managed. All that being said, applications that relate to rural, regional, and remote, socioeconomically disadvantaged communities, or culturally and linguistically diverse communities, the CAL communities, will be particularly welcomed. They're particularly relevant, and some of the feedback we're getting through our supporter surveys. Perhaps obviously, the chronic condition has to be relevant to the priority population. It's got to be something that is particular for that priority population and an unmet need. I'll get onto unmet need a bit later. But really, really important is that I guess the priority population needs to be engaged during, if you like, the development of the proposal and indeed its conduct. It's really important that the priority population is a meaningful part of the proposal and the project. And we are requiring that the project team needs to involve people from the selected priority population. And that might be as a chief investigator, that might be as an associate investigator, a collaborator, or as part of a formalised project advisory group. That's, I think, reasonably standard for any research dealing with a priority population. But it's a really important part of it because of the old saying, nothing about us without us, I think really, really applies in these cases. And element 3 is around the two research approaches. And essentially, these can be boiled down into trying out new or emerging treatment therapies or services or support models, or trying to refine or extend or improve existing treatment therapies or services or support models. So it's really about something that's perhaps novel or emerging that isn't really out there, but is showing promise as perhaps a way that could be useful in addressing a chronic condition in a priority population, or that there's some existing treatments which, with a bit of work, could actually be made more accessible, more useful, more relevant to the priority population. So that's kind of the way we've broken up the research project approach. New, novel and emerging, or refinement, which is really around existing. We do have some exclusions for the round, and these include things proposed which primarily focus on consumer awareness, education, disease diagnosis, or monitoring of disease progression. We understand that these sorts of things could form part of a proposal, but we don't want proposals that primarily or solely focus on those. It's also important to note, I guess, that THRF Group has provided and is continuing to provide some significant funding into palliative care research. So proposals about palliative care for a chronic condition aren't eligible. And we're also keen to make sure that obviously we want our community's funds to be used wisely and appropriately. So of course we don't want to see duplication or overlap with existing project or pending proposals. I mentioned I'll talk about the CIA requirements in a little bit more detail, and I guess this slide really outlines that, hopefully in a reasonably digestible way, in that essentially the CIA either has to hold a high degree by research, and that's a Master's by Research, or a PhD, which is Australian Qualifications Framework Levels 9 or 10, from a recognised institution, and be within 15 years, or equivalent research active time. There's a little asterisk there, which means it's about relative to opportunity, and we use essentially the NHMRC's relative to opportunity policy document as a guide in sort of calculating how that is worked out. Or if CIA perhaps doesn't hold an HDR, but can demonstrate they have an equivalent combination of relevant research skills, training, expertise, and experience that's the same as points 1 and 2, then we will consider that. I guess the evidence has to be made in the CIA's biosketch, and I'll talk about biosketches a little bit later. Because I guess the CIA is essentially an early to mid-career researcher, we do want to see that there's some sensible mentoring arrangements for the CIA, ideally within from within the project team. Doesn't have to be, but ideally, so that that person as an early to mid-career researcher is supported in running a project. They're the project lead. Now the project team, as mentioned before, we can have up to 4 CIs. If you like, the qualifications requirements pertain primarily to the CIA. There's some further detail in the guidelines around, I guess, the other CIs having relevant experience, being able to commit time, having a defined role, those sorts of things. Now, an individual can only be a CI on 2 applications and can only be a CIA on 1. There are some limits to how many times you can apply as a chief investigator. This is going to be a bigger round for us. We've run probably more tightly focused rounds in the past, and we've had the similar requirements in terms of CI limits, but I think this one will be particularly important because I think we're going to get a large number of applications. Associate investigators and collaborators can be indicated on the project, and that's fine. They don't count for the limits. They're people who might be providing, I guess, for intermittent or specific expertise on a certain project component, but might not be involved all the time, possibly. As mentioned before, priority population members have to be involved. They must be involved in some meaningful way. And that might be as a chief investigator, might be as an associate investigator, might be as, probably was quite recommended, having some form of project advisory group involving members of the priority population. As mentioned, we're going to welcome collaborations that extend across the border westward into Western Australia. We think that we're quite keen to see that, and we'll be keen to see that grow in future rounds as well. But it's also important to note that I guess each individual of the project team needs to have a defined role and capability. The combination of skills is actually bringing something to the table for the project. They're not just being named for their own sake. Now, the assessment criteria. We've got a reasonably simple sort of assessment rubric, if you like. Essentially, we're interested in unmet need, 20% weighting, approach, innovation and feasibility, 30% weighting, the impact, 30% as well, and the project team, 20%. I'll go through these in a little bit more detail in just a second. The key thing there is that we have a 5-point scale, unlike the NHMRC 7-point scale. So it's 5 points. The 5 is the highest, creme de la creme, top 5%. 4 is very good. 3 is good, and 2's okay. 1's probably not so good. So we're trying to, I guess, if you like, give a reasonable spread for our assessors to work with, but not have the great breadth that the NHMRC have, and which they only seem to use about 3 or 4 of their categories anyway. And I guess, given grants craft, people understandably will be strongly passionate about their area. We need to be able to get that message across to the reviewers. So just remember the 4 C's about being clear, concise, having coherent and consistency within your proposal, and cogent. We want to see compelling arguments, and the better you can do that, the higher your score. I should also note, I suppose, that assessment criteria are really viewed in light of the round objectives. So if something isn't meeting the round objectives, that's going to bring you down, or is partially addressing the round objective. It's going to bring you down in terms of the scoring, and that sort of applies across all of the criteria. So unmet need, just to talk about that in a little bit more detail. Again, 20% weighting. So really, it's is there an unmet need, a current unmet need for that priority population that's urgent, critical, it's significant, aligns with the round objectives as mentioned, and if solved, there's that real likelihood that it can lead to improved healthcare outcomes. Now, that's a reasonable number of points to cover, but those are the sorts of things that we want to be really clear on. We want to know that this is an important problem, and that there's evidence to back that up. This is about the project approach, innovation and feasibility. And this is again about making the case for the project that's going to actually address the unmet need that's been defined, that it's innovative, it's looking at new ways of doing things. Perhaps it's not, it's extending things, it's modifying things, it's perhaps using new technologies. It's not just perhaps more of the same. Now, I guess there's a refinement project, but we'd sort of see that refinement would be about thinking about how to improve or extend things. So that's perhaps where the innovation might come in for a refinement project, perhaps. Also want to know that I guess the project as it's being undertaken is meaningfully engaging with consumers, and as I mentioned, that might be with a project advisory group, or it might be with some consumer engagement forum, or there's many ways in which that can happen, but that's really important for us to see that there's that connection with the consumers, and in this case that we primarily consumers of that priority population. And I guess we're also obviously keen as a custodian of community funds that it's cost effective and value for money, and it's likely to achieve its stated aims with the resourcing that's being applied. Co-contributions from other sources are always welcome. They might be cash or in kind. Cash isn't required, just to make that clear, but I guess we'd probably expect that there'd be in-kind contributions from people's time and other things that can be brought to bear to this particular project. The third criterion is impact, and impact can mean many things to many people, but essentially what we're keen to see is that it's the project, if it's successful and goes well, it's going to, there's a good chance it's going to advance the field of research or the healthcare field. It's going to have relevant outcomes, and that there's a reasonably clearly described pathway whereby those outcomes could or can be sort of implemented to sustainably deliver patient healthcare impacts. And as I said, impact is a word that means many things to many people. And so I've just included here, I guess, kind of the translation pathway that they were talking about. So outputs such as publications, high impact publications, I guess from our reviewing perspective, isn't necessarily about impact. It will advance the field. We're talking about impact, and the translation pathway to impact is getting into more this side of the equation around having new methods developed, new clinical processes, new service models, those sorts of things. And the impact then is the, I guess, for the community members around getting that earlier diagnosis, or getting the recovery, or getting the better treatment, and getting that better health outcome. So that's just something to bear in mind as you frame your proposal. And lastly, the project team criterion makes up 20% of the weighting, and essentially it's a combination of the CIA and the team, that there's the combined capacity and capabilities to execute the project and deliver the outcomes, and that there's access to the necessary resources, infrastructure and technologies, data sometimes, and there's that relevant mix of expertise and experience that's really going to help the project be successful. And again, that's considered relative to opportunity. It's not necessarily track record. I mean, the number of publications and those sorts of things isn't as critical. It's around that capacity and capabilities, and I guess that mix of expertise that I guess we're encouraging the reviewers to look for. And in terms of the project team, we have, as mentioned, the CIA bio sketch, which at the EOI stage, which is 2 pages worth. If things are invited through to a full application, we'll ask for bio sketches for the other CIs. Again, 2 pages, not super onerous, but trying to elicit some of the key information that's useful for review. In terms of application process and timing, we use a Smarty Grants platform. Some of you may well have used that before. It's quite a common platform. That will be a link, as you see there on the screen, that will open on 12 noon on Monday, and that will be available, and you'll be able to log in, and you can download a preview of the application, so you don't have to do it all in one hit, but we will only accept applications via Smarty Grants. And I guess as mentioned, the stage 1 expression of interest will open and be open for about 5 or so weeks, with closing on the Wednesday, 7th of August at 4 p.m. sharp. And when I say sharp, I mean sharp. Smarty Grants does it for us. It locks it off and is no longer available from that time. Just a little bit more information about I guess the expression of interest. It's relatively brief, we ask for outlines of the unmet need, the approach, the impact, some indication of your team and the resourcing that you think you're going to need to have the project, As I mentioned, there's a CIA biosketch, 2 pages worth, and only for the CIA at that point. And very importantly, there's the administering organisation certification, and that does need to be included with the submitted proposal. Unfortunately, Smarty Grants does require that is dealt with in a kind of manual process, so a document does need to be uploaded separately once it's been signed by your research office. And I just want to, I guess, emphasise that incomplete, late, or incorrectly submitted applications will not be considered. We have had in the past sometimes where the admin org certification hasn't quite come through. Unfortunately, to be fair to all applicants, we've had to say, well, unfortunately, that's not going to be accepted this time around. So make sure you have the administering organisation research office, the information to them in time so that they can make sure that they're happy to submit the application. The general process and timing, as mentioned, I've talked about the stage 1 expression of interest. The review process will be indicatively 4 weeks. Again, we're relying on the kindness of strangers in terms of review, so it could be 4 weeks, could be 5 weeks. Sometimes it does spread out a little bit. But EOIs that aren't shortlisted at that stage will be notified, and those EOIs teams that are being invited to submit a full application will be notified as well. We'll allow around about 4 weeks for submission of a full application, and then following review, we might then go invite a subset of those full applications through to interview, where we might ask some of the questions that have been raised during the review process, and we'd hope, all things going well, that we'd have outcomes and notification to applicants about 6 weeks after stage 2 closes. So we're heading into the latter part of the year. This takes, as you can see, it takes a little time to go through the process. So I think that's about it in terms of describing the round at this point. The guidelines are currently available and will be available. And any questions that want to come through now can do so. You can also send them through later, and we'll attempt to answer the ones that come through now. But we'll also make sure that we've got a FAQ style document ready after the webinar sometime next week, I'd say. So that's probably it in terms of the presentation. I'll just run through the Q&A, and I think Kelly was going to perhaps take over at this point.
Thanks, Jim. Yeah, we've just got the one question so far on the Q&A, which relates to who the reviewers are likely to be. So if you wouldn't mind maybe just addressing the different types of reviewers and what people can expect from that process.
Yeah, so I guess the reviewers that we have lined up currently, and we're still chatting to a couple, are essentially sort of experienced health and medical researchers, as well as some people that are involved, let's say, in IP commercialization, licensing, those sorts of things, just to provide some sort of industry experience at EOI stage. And they, if you like, form a bit of a panel. So they're experienced people, relatively senior, had long experience in the field and in cognate fields. And at invitation to full application stage, we will be asking the invited teams to nominate or suggest the names of some reviewers that they feel would be able to provide qualified, expert and impartial review, and we can't guarantee that we'll use those people because there might be other problems. They might not be available, but they're the sorts of people that then be involved at the full application stage, if that helps.
Awesome. So the next question we have is about how long the EOI is.
Okay. Yeah. So the EOI is relatively brief. So each of those sections that I mentioned, the unmet need, the project approach, the impact, about 300 words each. And then there's a little bit of a page around how the team was going to work together. And of course, then there's the CIA bio sketch, which is 2 pages worth. So it's relatively brief. I wouldn't say it was, a 1-pager, but on the Smarty Grants form, which comes out at the end, it's probably ends up being about 6, 7, 8 pages, depending on how things are answered. And there's unfortunately a little bit of admin detail that has to be gone through as well, which Smarty Grants sort of formats in a very voluminous way, so it does run out. So it's not super huge, but it's not, I guess, as simple as a paragraph either.
Yeah, I think important to note a lot of that is tick boxes and white space, not 6 pages of text. The actual text itself, as you said, is about 300 words for each question, which there's 3 or 4 questions of that length. So. And also probably important to add that you can actually preview the form now via Smarty Grants. So if you go to our website and look at the grant opportunity page and go to the link, whilst the round is not yet open, you can preview the form now. So you can get a look at what you need to actually include. The next question we have is about, can you please clarify that the 3 populations are the only priority populations that can be considered? Do you want to just clarify that one, Jim?
Oh, right, yeah. So, sorry if I gave that impression that they were the only ones. They were ones that we would particularly welcome. I guess priority populations, if they can be reasonably demonstrated, and I know there's some priority populations that say in the returned veterans space or the LGBTQI plus space, those sorts of things. So any sort of demonstrable priority population can be applied for. They were given. Those 3 that were given were around the rural, regional and remote, the low socioeconomic status, and the culturally and linguistically diverse were put forward as ones that we'd welcome, but they're not by no means restricted to just those 3. Very good.
That's the last question. We just had a comment about sharing the PowerPoint, which we can do. And I think our intention is to share the recording of this webinar as well. So hang on, we've just got another one. Let me have a look. So follow-up question, any idea of how many EOIs will go through to full application?
That's a very good question. How long is a piece of string? It may depend. I think, and again, this is ballpark because it's going to be a much larger round than probably we've run previously. In our previous rounds, it's probably been about at EOI stage, maybe let's say 50% go through to full application, maybe thereabouts, give or take, a few tens of percentages. So maybe around that number. It's going to be really hard to know. I can't really be more definite than that. Sorry.
A question about the interview. What is the interview phase? It sounds scary.
Oh, it's very, very scary. So essentially, so at the after the review of the full application, there's quite often a few comments or queries that might come back from the review process, and it's really just an opportunity to catch up with the applicant team and have a bit of a discussion about those. And we how we've done it in the past is to provide the points of query comment that have come through from the stage 2 review to the applicant team in advance, a couple of days in advance, so they've got time to think about what they might be, and then just talk it through. It's I don't think it's especially scary. I guess I haven't been on the other side of it, but it's very much a discussion rather than being I guess a very formal or rigid process, if that helps.
Okay, so we just had a follow-up query regarding the way in which EOIs, I guess, are chosen to go forward. So is that based on a score or a certain number from a rank?
Sorry, just score. Ah, right. Okay. So I guess the reviewers, each individual reviewer will provide a score for an EOI. Based on those weightings, we'll come up with a score for that EOI, and then there's a combination of the reviewers who've reviewed that particular EOI will provide, if you like, at that point a provisional sort of combined wisdom of the reviewers score that will then be ranked against the various other EOIs. So some will have higher scores, some will have lower scores. It will provide a provisional rank, and that will be provisionally the rank in which the EOIs are discussed by the reviewers and selected. And again, it's a peer review, as we all know, is something of an imperfect art, but it is about getting the sense of and a consensus amongst the reviewers about which proposals are on the rank, sufficiently high on the rank that are worthy of being invited through to full review, and those which unfortunately miss out, if that helps to answer the question.
I think that is all the questions that we currently have. So unless anyone is madly typing a new one in, we might have reached the end.
Yeah, might have reached saturation point. They're probably sick of me talking. So excellent. Well, thank you everyone for attending. I hope it was informative. This was as I said, was our first webinar that we've run. Hopefully it was okay. And oh, hang on, looks like there might be another query. It's just popped in. Projects that focus on I assume it's allied health staff working in these populations will be accepted. I guess if it's meeting all the various requirements as outlined in the guidelines, allied health staff I guess are part of the healthcare service or supports for priority populations, and then that seems prima facie at first pass on the basis of information provided. How many caveats can I put in? Seems okay, but I think definitely have a look at the guidelines. If you do have any further questions or want to have a further discussion about some of the detail, then by all means contact us via the grants email address, and we'll see what help we can provide in terms of giving you some further guidance. Excellent. All right. And again, this is not the end of the questions. If anyone sort of goes away and says, oh, I should have asked something, please send it through and we'll do our best to provide a sensible and useful answer. Having worked in a research office before, we understand that applicants like to have as clear an answer as possible and not just simply a pointing to a guidelines. So we'll try and do our best to make sure that it's useful. And we work, just to close off, we work closely with all of the research officers of the administering institutions and have good productive relationships with them, and can work with you and your research office to help resolve any issues. Lovely. Thank you for your time, and look forward to seeing some interesting EOIs. I think it'll be a very good round, and I'm really looking forward to it. Excellent. All right. Well, have a good rest of the day, everyone. I'm sure we'll hear from you soon. Cheers. Bye.